Okay, so we will continue from risk factors for polylithiasis. So we said that there are factors that can increase one risk. One is obesity. So obesity is one of the risk factors. And then people who take in food containing high fat. So who taking too much meat, etc., are also at increased risks of getting this condition. And then it has been found to be common in females than males. So it's at a ratio of 8:1, right? So 8 women is to one or eight women is to just one man, right? And then pregnancy is also one of the risk factors. And then as you age, your rates of getting this condition also increases. And then family history, and then women who has given birth severally, right? So multiparous women, and then women who are in their menopause and then they are taking artificial hormones also have increased risk for, especially those taking estrogen therapy. And then diabetes can also increase your risk. And then oral contraceptives. Yes, nowadays the use of oral contraceptives among the youth have become very common. So it's also one of the factors that can increase a person's risk to this condition that we are talking about. And then apart from that, some drugs can also increase a person's risk to this condition. Most of the time, if a person is having cholecystitis, it means that the liver has to be removed. So it depends. We will start with medical management, right? So if it's resolved, then that is fine. But if not, before we will consider treating it surgically. But with polylithiasis, the stones have to be removed. It can be done through surgical means, right? Okay, so let's look at nursing management for somebody with cholecystitis and then polylithiasis. Nursing management for cholecystitis and then polylithiasis. We said that people with polylithiasis and cholecystitis have pain that is located at the right upper quadrant. So as nurses, we should manage the pain, especially when prescribed analgesics is prescribed for them. We have to administer it as prescribed. And then we have to assess the pain level, reassure them, and then sometimes we engage patients in directional therapy and all that. If patient is vomiting, we administer prescribed IV fluids, we assess the vomitors, manage the patient on intake and output chart, and assess for the signs of hydration, dehydration, we monitor the weight and all that. And then we have to, depending on the stage, right? If patient is being prepared for surgery, then within the 6 to 8 hours to the surgery, we don't give anything by mouth. So we maintain milk per course 6 to 8 hours to the surgery, right? And then if patient is allowed to eat, then we have to serve water frequently. Right? So we have to serve more of water. We have to eliminate fatty foods from the patient food because it can cause more pain, right? And then we have to also monitor the vital signs of the patient, very important. And then we said people with this condition will have yellowish discoloration of the skin. So we have to assess the skin, we have to assess for the color of the skin as well as signs of pruritus, itchiness of the skin, right? And then apart from that, we said that people with this condition have difficulty with absorption of vitamins, some vitamins. So we have to give vitamin supplements as prescribed, such as A, D, E, K, right? Fast soluble vitamins like A, D, E, and K, as prescribed should be administered. And then if they are having pruritus, as we have talked about already, we have to help manage that, right? So people with this condition, cholecystectomy can be done. Cholecystectomy can be done, right? So when the gallbladder is infected, right, where you have cholecystitis, or where there is stones, or where there is cancer of the gallbladder can be removed by the process known as cholecystectomy. And then sometimes the stones is what is removed, and then removal of the stones is termed as choledochotomy. So the first one is cholecystectomy, and then the second one is choledochotomy, whereby an incision is made and then the stones or the stone is removed. And then we have another one known as choledochostomy. Is also another one of the surgical procedures, right? So choledochostomy, that is when the bowel, the stone, instead of staying in the gallbladder, it moves from the gallbladder and it lodges in the common bile duct, right? So when an incision is made into the common bile duct and the stone is removed, that is what we term as the choledochostomy. And we can also do another surgical operation known as choledolithotomy. With the choledolithotomy, the stones is removed from the common bile duct, right? It's just like the choledochostomy. Okay, so these are the surgical management for or operation for somebody who is undergoing cholecystectomy or who is undergoing surgery on the gallbladder, right? And apart from the nursing management that we talked about, most of the time the pre-op is the same as other abdominal surgery. So management is the same, is similar to other abdominal surgery. So NG2 may be passed, some prescribed enema or laxatives may be given. Administration of vitamin K is important for this patient because of the increased risk of bleeding, right? And then the difficulty in absorbing vitamin K, right? So sometimes artificial vitamin K or external vitamin K may be given for this patient. All laboratory investigations should be done before the patient undergoes the surgery. Post-op management is also similar, right? But there's something that is specific that I want us to talk about. Most of the time they will come from the theater with a tube that is inserted to drain the bowel, and the name of the tube is called the T-tube. And I want us to see how the T-tube looks like. T-tube, right? So this is specific for people who undergo either cholecystectomy or choledolithotomy or choledochostomy, etc. So let's look at how the T-tube looks like. Let's see how the T-tube looks like. This is the T-tube we are talking about. So this is inserted so that the T part of as you can see, we have the T part. So the T part goes inside the body, and then the open end comes outside the body so that the bowel will flow through the open end of the tube. Okay, so we will move on. So we saw how the T-tube look like. Right, so as I said, it will be placed at the theater. The T end goes inside the body and then it helps to drain. So So it goes in the bile duct, right, the common bile duct, so that it drains the bile outside the body, right, till the incision heals, right, so that it can be removed, so it's placed temporarily in the body. Okay, so as nurses, how are we going to care for these two? One, you have to, before the patient goes for the surgery, you have to explain to the patient that the patient might come with a tube, and then you have to explain the rationale for the tube, right, so that the patient will not be pulling the tube and they will not be anxious when after the surgery they see a tube inserted in their body. So the first thing is you have to explain the reason of the tube to the patient, and then since it's a tube and then it's going to drain fluid from the body, the bowel, you have to assess the color of the fluid, the amount, the consistency of the drainage every shift, right? So during the morning shift it should be assessed, which is about 6 to 8 hours. So every 6 to 8 hours you should assess the color, the amount, the consistency. The drainage initially is bloody, right, because of the incision. The drainage initially is bloody, but as time goes on it changes to greenish brown, right, and then it's expected that initially the amount of drainage will be around 300 to 500 mils. 300 to 500 mils. Right, so just like the sachet water that you take, so about 300 to 500, and we said that it's initially bloody, so it will be bright red and then it will change to the 300 to 500 is per 24 hours, right, and it will change to greenish brown. The amount will be less than 200 mils per day after 4 days. So as time goes by, the drainage decreases gradually. So within 4 days you can have about 200 mils per day, and then when the drainage stops, the physician is informed so that the tube will be removed, and then the incision will continue dressing the incision till it heals. Assess the drainage for continuous flow. So you have to assess for continuous flow. When it stops, the physician should be informed, and then whenever a tube inserted in the body removes, it should not be re-inserted. The physician should be notified, right, and then dress the incision site daily after the second day post-op, right. So the incision is a wound that has been created, right, so it has to be dressed so that it will not become infected. So when during the second day post-op, you start dressing the incision using aseptic technique, and then you have to make sure the dressing at the incision is dry, right, so the patient should not wet it, the patient should not be touching it, right. So these are things that can cause the incisional site to be contaminated, right, so you should avoid all these things. And then you should also make sure patient does not lie on the tube, right, so the patient should not lie on the tube. And apart from that, when dressing the incision site, the site should be assessed for edema, for rashes, for things that signs of infection, right, and then if these are observed, it should be reported immediately. And then prescribed analgesics should be given to manage pain, and then prescribed antibiotics should also be given to prevent infection at the incisional area. And then apart from that, you should also check to make sure the tube daily, to make sure the tube is well secured, right, and it's not cleaned or it's not blocked, right, so you should also be assessed for that. Never irrigate or aspirate or clamp the tube, right, so you should not clamp the tube with an artery faucet unless it has been ordered. Otherwise you should never clamp the tube, right, and then the tube should also be assessed for leakages around. right? Since if there are leakages, it can fall on the skin, and then the bowel most of the time irritates the skin, so you have to assess for leakages. If it's present, you have to report, right, immediately. Okay, and then apart from that, if the tube is connected to a bag, then it means that you have to empty the bag when the bag is half or two-thirds full. When the drainage ceases, the tube should be removed. The T-tube is clamped for 1 hour before and after meals to allow the bowel to flow into the duodenum to determine the patient tolerance. Right, so before the T-tube is removed, you have to clamp it for 1 hour before meals, and then when patient eats the food, you clamp it again. So clamping it will let the bowel that is passing through the tube move into the duodenum. Right, so when it moves into the duodenum, you assess the patient reaction towards the food, right? And then if patient does not have any indigestion or difficulties, then it means that the tube can now be removed without any complications. If distress occurs, tube is unclamped and then physician is notified, so it means that the tube cannot be removed, right? And then you ensure patency of the tube. So before removing, reassure the patient, then you put patient in semi-fowler's position, and then provide privacy. When it's connected to a bag and then it's full, you have to empty the bag, and then you clamp the tube, and then the stitch that holds the skin to the tube, you remove it, and then you ask patient to perform what you call Valsalva maneuver. Valsalva maneuver. So with this, the patient taking a deep breath and then hold it, right? And as the patient hold, it's just like deep breathing exercises. So we ask patient to take in deep breath, hold it, and as the patient is breathing out gently, you remove the tube. It diverts the patient's attention from the procedure that you are doing. So Valsalva maneuver is also done, and then once the tube is removed, sterile dressing is applied, and then the patient is stamped and made comfortable in bed. Complications. Some complications that can occur after this procedure is bleeding, infection at the site, right? And then it can also lead to cholangitis. Cholangitis is inflammation of the bile duct, and then it can also lead to biliary liver cirrhosis. It can lead to abscess of the gallbladder and all that if not managed well, and then bacteria get access into the gallbladder or the liver. It can cause some complications, right? It can even lead to cancer and peritonitis if not managed well, right? Okay, so this is the end of the lecture on cholecystitis, cholelithiasis. Let's look at pancreatitis, which is similar to the cholecystitis, cholelithiasis, right? Because they have similar functions, right? So it's similar. Pancreatitis, which I'll do it briefly, is just inflammation. There's an inflammation of the pancreas, and then it also occurs as a result of bacteria or viral invasion, and then people who abuse alcohol, and then gallstones can also lead to pancreatitis, right? Apart from that, other risk factors such as genetics, autoimmune disorders. Autoimmune disorders is where the body fights against itself, right? So when there is an autoimmune reaction, it can also lead to pancreatitis, right? And then apart from that, trauma to the pancreas, right, can also lead to, and people with HIV or mumps, the virus can also cause pancreatitis. And then it can also occur in people with penetrating duodenal ulcer, right? Because the pancreas is connected to the duodenum. If you have penetrating duodenal ulcer, it can also affect the pancreas, so it can lead to pancreatitis. And then surgical procedures on the stomach, on the duodenum, can also, if it's not done well, it can also lead to pancreatitis, right? So these are causes and then things that increases one's risk to pancreatitis. Then signs and symptoms is similar to the signs and symptoms of cholelithiasis, cholecystitis. It's similar. It's similar. So you have pain, you have nausea and vomiting, fever. Sometimes there is signs of shock. So hypertension, there is jaundice, there will be clay colored stools, that will be abdominal tenderness, just like the ones we talked about. So it means that management is the same. Management is the same. So the management is aimed at relieving the pain, preventing infection, so giving prescribed antibiotics, and then giving prescribed antiemetics if patient is vomiting, and then prescribe antispasmodics, right? Because excessive contraction of the duct, especially the common bowel duct, causes or increases the pain. So antispasmodics help to prevent excessive contraction and then helps relieve the pain, right? And then apart from that, you should assess for signs like yellowish discoloration of the skin. And then they also have a sign known as the Gall's sign. Gall sign. C-U-L-L-E-N-S. Gall's sign. Gall's sign is a bluish peri-umbilical discoloration, right? So there's a bluish discoloration around the umbilical region in people with pancreatitis. And then they can also have what you call the tennis sign. These are specific for people who have tennis sign, people who have pancreatitis, right? With a tennis sign, there is also a bluish dark discoloration on the skin, right? That also occurs in people with pancreatitis. And then you have to also make sure if patient is an alcoholic, patient to stop taking the alcohol, and sometimes they have abdominal distension and difficulty in breathing. So you can make a cardiac bed for them and then put them in semi-Fowler's position. Semi-Fowler's position. There are several complications that can occur in people with pancreatitis. One of them is abscess of the pancreas, cancer of the pancreas. It can also lead to some pulmonary complications like pleural effusion, atelectasis, pneumonia, etc. Right. Diagnostic investigations is not different from the ones we've listed. So it can lead to, we can do ultrasound for them, CT scan for them, we can do MRI, etc. It can even do X-ray, and then apart from that, we can also do full blood count and others. Yeah, so the management is, if it becomes cancerous, that is where the pancreas will be removed, right? So management is similar to all abdominal surgeries, pre-op and post-op, and most of the time you manage the signs and symptoms that the patient is presenting. So we will end our lecture for today here. Then we will continue next week.